This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I am sitting here this morning with Dr. David Sheldon, one of our CSAP 17 authors, who has agreed to speak with me today. David, before we get started, can you share with our audience a little bit about yourself, like where you're located, your primary focus of your clinical practice, and maybe a little bit about how you spend your typical day or maybe typical week, if there is one of those?
Sure, and I just want to say thanks for having me for CSAP Audio Companion. My name is David Sheldon. I'm a general surgeon in Montana. My practice is in Kalispell, Montana, in the northwest corner of the state. It's a very rural state, as you know, and my practice focuses on support of complex surgical problems in the state of Montana. I would say that the bulk of my practice is surgical oncology, for which I've trained, and I take care of a lot of very broad types of surgical oncology problems. And I would say that on any given day, I could be doing anything from hepatobiliary disease, pancreatic disease, soft tissue sarcomas, gynecologic oncology, and even head and neck cancer, depending on what shows up in the clinic that day. And I maintain a very easy access for all the rural surgeons in the state so that we have options to take care of Montanans here in Montana.
I would just tell our audience that you've got quite a network organized out there, and the support that you give all those Montana surgeons, I know, is appreciated many times over. So I thank you for that.
Well, thank you.
Now that you've shared those thoughts with us, let me tell our audience a little bit about what I would like to talk to you about, and that is related to things that a general surgeon might encounter related to various cancer. Given your expertise, I've selected some of the topics from oncology and the skin and soft tissue categories of CSAP 17, but we're going to touch on some of the oncology topics from the other categories as well. So I'm looking forward to this discussion, so let's get started. The first topic I'd like to talk about is something that all general surgeons sees, and that's skin lesions. Obviously, the background here is, at least one background topic is going to be melanoma. So let me just ask you a general question. When I see a patient with a skin lesion, and I'm thinking, well, this may represent a melanoma, what kind of biopsy are we supposed to be doing these days?
Well, it's a topic of discussion, but I think any general surgeon should be comfortable managing pigmented skin lesions. And of course, an index of suspicion always is first and foremost, and we look at the characteristics of the skin lesion itself, and that will determine what type of biopsy should be performed. We all know about the ABCDs of melanoma: asymmetry and irregular borders and variegated colors and diameter size and evolving size of the lesion. And this will play into how you perform a biopsy. The real board answer for a suspected melanoma is a narrow excision with 1 to 3 millimeter margins for both diagnosis and potentially curative excision, and that way it won't alter further management. For very large lesions, this may be somewhat prohibitive, and a punch biopsy of the perceived thickest area of the lesion is perfectly reasonable.
When you say punch biopsy, and you say the thickest region, is it okay to biopsy the middle, or do you want to biopsy an edge so you have some kind of relationship with the skin architecture?
Well, personally, I want to know the Breslow depth or the Clark level of the lesion, and Breslow depth comes into play much more often these days. So a lesion that is clearly a large lesion that's obviously going to be deep, the punch biopsy is largely going to be for diagnosis so that further management can be dictated. I don't necessarily need to have a epidermal interface in that situation if it's an obvious melanoma. Now,
there's at least one or two of the major cancer centers across the United States that have been publishing data on shave biopsies, and I was taught that they're taboo. Is that still true?
The answer is maybe. A deep shave biopsy with complete excision of a lesion is perfectly reasonable. A shave biopsy can make cosmetic reconstruction and the size of the subsequent excision somewhat more problematic due to the saucerization of the lesion. But if you get a true depth of the lesion, then a shave biopsy should not prevent adequate further care. A superficial shave biopsy, however, that transects the tumor and doesn't give you the adequate information is probably not the right thing. So the technique of shave will determine whether adequate biopsy has been performed.
Once you have a diagnosis, what do I need to know about what margins are necessary when I excise that primary tumor?
Melanoma is interesting. The recent history of the management of melanoma is fascinating. Large database series have given us high-quality evidence from statistical probability of how to manage melanoma. If you have a T1 lesion, one is less than 1 millimeter in depth, 1 centimeter margins would be completely adequate. For intermediate thickness lesions from 1 to 2 millimeters, a 1 to 2 centimeter margin would be perfectly appropriate, depending on whether you have other factors in the histologic analysis of the tumor. For larger lesions over 2 to 4 millimeters of depth, 2 centimeter margins would be appropriate.
And the other thing, obviously, a physical exam to look for satellite lesions or anything else that's disturbing on an extremity or a truncal melanoma is important. But does everybody now get a sentinel lymph node biopsy?
It's important to indicate that sentinel node is not for everyone. One should look at a sentinel node as a staging procedure. There is high-quality evidence that demonstrates that the use of sentinel node biopsy in certain melanomas provides a survival benefit, specifically a disease-free survival benefit in intermediate thickness melanomas. The 2018 revisions of the AJCC staging indicates that T1 lesions less than 0.8 millimeters or T1A lesions have very little propensity to have occult nodal metastases, and in most situations a sentinel lymph node biopsy in a T1A lesion would not be indicated. For anything over a T1A lesion, one can consider a sentinel lymph node biopsy depending on whether the presence or absence of a mitotic rate, ulceration, or other poor histologic characteristics. And this should be a discussion between the provider and the patient to determine the utility of sentinel lymph node biopsy. Again, it's a staging procedure. For intermediate thickness melanomas, anything over than a millimeter or size to up to 4 millimeters, sentinel lymph node biopsy would represent the standard of care.
Let me ask you if you've got any help for our audience. You've got let's say a 3 millimeter melanoma in the middle of the back. Do you have any tricks about how you decide where you go for your sentinel lymph node biopsy?
Well, the first thing would be a very thorough, adequate nodal assessment in that situation. Lymph node patterns are predictable but don't always adhere to the rules. So in a melanoma of the mid-back, either axillary or either groin nodal basin would be at risk for occult nodal disease. Imaging has very little role in that situation if you don't have any evidence of nodal disease by physical examination. So a sentinel lymph node biopsy must be done in conjunction with your radiologist to map the whole trunk and to watch the lymphoscintigraphy for any nodal basin that might be at risk. And it might be several.
So is that just done at the time of your sentinel lymph node biopsy, or does the radiologist do a formal lymphoscintigraphy exam to figure out which way the drainage is going?
I prefer to have a lymphoscintigraphy in that situation.
Now, the other thing we had a lot of discussion about in CSAP 17 is you kind of mentioned that the node is positive, but what if the node just has what is now termed, I believe, micrometastases, and that's all you see, just a few cells throughout the nodes that you have harvested with the sentinel lymph node biopsy?
This is an evolving pattern of management in melanoma these days. I would say that more and more, most surgeons would not recommend a completion lymph node dissection or a therapeutic lymph node dissection for microscopic disease in a nodal basin. The chances that you recover any more melanoma after a positive sentinel lymph node is less than 20%. And this has been garnered from high-quality data from the multicenter lymph node trial. So Microscopic disease is a harbinger of potential systemic disease and an indicator for further treatment. But completion lymph node dissection should only be performed with gross disease or people at high risk for having relapse in the nodal basin, such as 4 or more sentinel nodes or bulky disease in the sentinel node.
And if you do have a node that has micrometastasis, what changes in treatment do we have available to us?
Again, this is an evolving treatment and one that's been quite fascinating over the last several years. Typically, if a person had stage 3 melanoma or regional melanoma in the lymph nodes, we didn't have very effective therapies, and typically interferon alpha was offered for up to a year with little to no benefit. These days, we have very high-quality evidence that demonstrates that immunotherapy with CTLA-4 antibody-directed therapy or anti-PD-1 derived therapy is very effective in treatment of systemic melanoma.
Are you talking about these monoclonal antibodies that we now have available, ipilimumab and pembrolizumab? Is that correct?
Yes, that's correct. Their initial data to indicate that immunotherapy with ipilimumab was effective in melanoma has been around for several years at this point, and anti-PD-1 therapy or programmed cell death pathway therapy with pembrolizumab and nivolumab is much more effective and associated with less toxicity. And this is a rapidly evolving field.
So those treatments are used for the micrometastasis. If you have gross or macrometastasis, then you do a therapeutic lymph node dissection. Do any of those patients get any of these new drugs?
The answer is probably, in my personal practice, if you have gross disease in a regional nodal basin, a therapeutic lymph node dissection would be performed in the appropriate patient for regional control, whereas that patient would also be at risk for systemic disease and relapse. So adjuvant therapy would be indicated with these new immunotherapy types of treatments.
Well, there's one question in CSAP we haven't seen in a while, and that is it concerns itself with a subungual melanoma. And if I remember correctly, this used to be a place where amputation was recommended, but have we changed the principles of management regarding subungual melanoma as well?
Subungual melanoma is an interesting kind of melanoma and was initially thought to be a subtype of melanoma that was much more aggressive. However, that's probably just not the case. Melanoma of the nail beds should be treated just like another melanoma in terms of appropriate excision for the depth of the tumor. And so if an in situ melanoma or a thin melanoma of the subungual region is identified, then amputation sparing or limb sparing techniques can certainly be applied if possible. Having said that, sometimes it's just easiest for a very distal amputation to manage the tumor.
And when you do that distal amputation, is that guided anyway by a biopsy, or is a distal amputation acceptable therapy and then evaluation of the histology and then making final decisions?
Oh, I think the principles of melanoma surgery apply here as well. So a biopsy to guide therapy ahead of time would be in order.
All right, well, let's talk about a cell that appears on most CSAPs, as it did this time, and that's a Merkel cell tumor. So what is this?
Basically, a Merkel cell tumor is a primary cutaneous neuroendocrine tumor, equivalent to a small cell lung cancer, essentially, of the skin.
Okay, and is it treated similarly to melanoma, or does it have its own treatment pathway?
It has its own specific treatment pathways, and there's some similarities to melanoma in that it's a cutaneous tumor and sometimes sentinel lymph node biopsy comes to play. But it's a much more aggressive tumor, and multimodal therapy is almost always involved with the treatment of Merkel cell carcinoma in the right patient.
And so biopsy is indicated to make a diagnosis. Is depth a concern with Merkel cell?
It's not so much depth, but size. Small lesions less than a centimeter or so, sometimes surgical therapy alone suffices. And essentially you want to have a 1 to 2 centimeter margin with usually a sentinel lymph node biopsy in that situation. For larger tumors, multidisciplinary treatment with radiotherapy, possibly plastics and reconstruction comes into play as well.
So radiotherapy for a Merkel cell is more important than for a melanoma. Is that kind of a true statement?
I would think most centers that deal with Merkel cells on a high volume basis would say that Merkel cell tumors are one of the only tumors of the skin and almost any type of tumor where radiotherapy can provide a survival benefit. So large tumors that are resected, adjuvant radiation to the bed of the tumor is associated with longer disease-free survivals in retrospective studies. There just aren't enough of them to provide good, high-quality randomized data.
David, is there anything else that we should tell our audience about regarding melanoma before we leave the topic?
Yes, again, this is a rapidly evolving field, and the systemic treatment of high-risk melanoma is much more satisfying than it has been in the past. Up to 50% of melanomas, as most people will have read, harbor a BRAF mutation or BRAF mutation, and this signaling pathway also plays a role in how we treat melanomas. We know that we can have very impressive responses to BRAF inhibitors, but the responses can be short-lived. So most major cancer centers that treat disseminated melanoma will use ipilimumab, nivolumab, pembrolizumab treatment pathways up front, and then say BRAF mutated melanomas to treat those pathways in the appropriate patients in the instance of failure from PD-1 therapy.
So what I think you're saying is now that just like colon cancer, where the specimen is examined for genetic profiling, so melanomas now are being genetically profiled so we can identify some of these markers that would indicate better response to some of our chemotherapeutic agents or our immunotherapy agents.
That's correct. So almost all melanomas should be subjected to a BRAF mutation analysis for future treatment if necessary. In the BRAF mutated tumors, this leads itself to potentially treating tumors with dabrafenib or MEK receptor pathways inhibitions. But again, most disseminated melanomas are treated with programmed cell death lineage type of treatments up front.
So let me ask you an obvious question that just popped into my mind. Have we relegated interferon treatment, which you already mentioned today, to our history books?
The practical answer is yes. Interferon as a systemic treatment still is an option, but given the efficacy of modern immunotherapeutic type of agents, the opportunity to use interferon as a primary treatment is few and far between.
Well, let's leave the skin and let's talk about sarcoma. And I realize that many of these patients will be referred to cancer centers, but I would like to discuss a few issues that do appear on sarcoma in CSEP17. First one, let's talk about extremity sarcomas. And let me start with a case. How about you're seeing a 50-year-old male who fell playing tennis and bruised his left thigh. And that took place about a month ago. So after the bruising resolved, he noticed a mass, and on physical exam, he's got a 5-centimeter non-tender lesion in the vastus lateralis muscle. It's hard, it's non-mobile. Do I image this patient, or do I proceed right to biopsy?
Well, the most important thing about dealing with soft tissue tumors is a very strong index of suspicion that something could be going on that needs serious therapy. All of us that deal with sarcomas on a regular basis have heard a story about someone who has injured themselves and they noticed a bruise or a lump or a swelling and it just didn't go away. So an index of suspicion for whether this is injury-related versus neoplasia guides your therapy. For something that you're describing that is firm, that is deep, that is fixed, potentially have been growing over time, should be imaged, in my mind, first to know what you're dealing with.
And the imaging that you would prefer or that the literature prefers?
Contrasted MRI would be standard management.
And so that shows you that this lesion is truly there? Are there any other unique characteristics with an extremity sarcoma on MRI?
Well, MRI can be diagnostic in some types of sarcomas. It's important to remember that there's about 10 to 12,000 cases of sarcoma per year in this country, but there's many, many different subtypes of sarcoma. And about 40% of them are extremity sarcomas, and the vast majority of those are going to be either liposarcomas or fibrous tumors. And MRI is useful in some types of fibrous tumors in making a diagnosis and can certainly be diagnostic in liposarcoma. And that may, in some cases, obviate the need for a biopsy, but I believe that biopsy is complementary to MRI, and the MRI can also direct you to biopsy the appropriate place of the tumor if there's specific areas of concern, specifically with dedifferentiated sarcomas with solid components.
And the biopsy we're talking about, is that excisional? Is that an FNA? Is that a core biopsy? What should we be doing if we want to follow a pathway that's kind of the most optimal?
I would say the most optimal way to biopsy a lesion would be with an image-guided core needle biopsy. Sometimes this can be performed in the office. Sometimes it can be performed without imaging, but a core needle biopsy is the most appropriate. We have had a historical use of excisional biopsies or incisional biopsies, and I would say that most modern sarcoma centers would shy away from this at this point.
If I make a mistake and excise the mass and it comes back sarcoma, I realize that's not ideal, but is it always as bad as we were told?
It really depends on the type of sarcoma. Again, a high index of suspicion should guide therapy. I would implore surgeons that deal with soft tissue tumors on a regular basis to be very concerned about a fibrous tumor on an extremity. These are your bad actors that typically the first operation is the best operation to control them. It happens all the time where a previously thought to be benign lesion is excised and it's a sarcoma. And again, while not ideal, it's usually manageable with limb salvage techniques.
Now, I remember during our committee discussion that we put 5 centimeters in the case that I just gave you to make sure that we gave the impression, at least, that this was a fairly large lesion and would hopefully avoid somebody trying to just pop it out. So when you've got a smaller lesion, is it okay to do an excisional biopsy, or should we still be doing core biopsies on that 2.5, 3 centimeter lesion?
Again, an index of suspicion would apply as well. For most 2 centimeter lesions, they can usually be managed locally with a wide excision with appropriate margins if a sarcoma is known preoperatively. For a diagnostic approach, narrow excision of a small lesion probably is not going to do the patient a tremendous disservice. For larger lesions, almost any surgeon that's well-trained should take a pause and want to know what they're dealing with before they go and excise it.
And when you say larger lesions, what's your cutoff?
I think anything over 3 centimeters that is deep to the subcutaneous tissues should cause a general surgeon to start thinking really hard that something more than just a benign lesion is here. Again, something that's firm, something that's deep, something that's large, or something that's rapidly growing is very likely to be a sarcoma.
So you make the diagnosis by core needle biopsy. You mentioned 40% of sarcomas are extremity sarcomas. So in the extremity, are the margins the same for all cell types?
No, in this day and age, complete excision with 1 centimeter margins would be appropriate for a large variety of sarcomas, but some subtypes that are more aggressive or have a predilection for local recurrence, like fibrous tumors or myxofibrosarcomas, dermatofibrosarcoma protuberans, 2 centimeter margins with the investing fascia would be appropriate.
Now, we've got a large lesion that's localized into one compartment of the thigh, let's say. Is amputation still necessary, or can compartmental resections be done with excellent outcomes?
Function-sparing approaches to limb extremity sarcoma are the rule these days. Overall, less than 5% of sarcomas result in amputation as a primary treatment modality. Compartmental resections in and of themselves are not necessary if the tumor can be removed with the appropriate margins with a normal rim of tissue. Again, 1 to 2 centimeter margins depending on the cell type.
Now, the other discussion we had, and actually it's in one of the critiques, I believe, is when the mass sort of envelops the neurovascular bundle, and people talk about bivalving that mass and sparing the neuromuscular bundle. Is that something that is also routine now?
That would be standard management. Major compartmental resections with sacrifice of arterial or large nervous structures is almost never performed as a primary treatment modality. Your MRI preoperatively may give a clue as to the nature and the relationship of the tumor with these structures. And in this situation, multimodality therapy with a neoadjuvant technique is usually prescribed at most major centers with high-grade tumors that involve major limb-threatening structures. Surgery in and of itself, usually skeletonization of large structures such as the sciatic nerve, the superficial femoral artery, etc., would be appropriate.
And in those kind of cases, is there adjuvant chemo? You mentioned neoadjuvant. Is there adjuvant chemo or radiation therapy that improves outcomes?
Again, with many different types of sarcoma, it really depends on what you're dealing with. In general, high-grade sarcomas with a high predilection for local recurrence usually would end up with some type of adjuvant therapy, either radiation and much less likely chemotherapy. And if the nature of the tumor is known beforehand, sometimes radiation therapy and or chemotherapy is prescribed ahead of time when a functional limb-sparing approach is desired. It just highlights the necessity of really big sarcomas with limb-threatening characteristics probably should be managed in a large sarcoma center.
Let's move to another area of the body where sarcomas are seen, and another favorite CSAP question is how to manage, or let's say sometimes even diagnose, retroperitoneal sarcomas. So usually large, bulky when they're diagnosed. What do we need to know about these sarcomas regarding cell type?
The most common cell types in retroperitoneal sarcoma would be liposarcoma or leiomyosarcoma. And again, the principles of management include what type of tumor you're dealing with and what is the grade of the tumor, because this will guide further therapy. They're particularly difficult tumors to manage because they're by definition deep and by definition large, because most of them are not found incidentally, they're found for symptoms. And the visceral things that sarcomas are in proximity to make complete resection without serious morbidity very difficult.
So the management approach when you have one of these large sarcomas is to resect. You mentioned that they kind of are in proximity to a lot of vital structures. Do we sacrifice vital structures when we're excising a retroperitoneal sarcoma?
Well, most modern series of looking at retroperitoneal sarcoma in terms of surgical management, in over 80% of the cases, require multivisceral resection. Neoadjuvant techniques don't seem to decrease this tremendously, but neoadjuvant techniques are sometimes applied depending on the type of tumor. My personal practice is to remove the tumor en bloc with a normal margin, if possible, up front. And a certain percentage of these people will not recur, and some of them will recur, in which case you will have to deal with a multidisciplinary situation again.
Now, the other question in CSAP that we discussed a fair amount, and I do not believe it made it into CSAP 17, was just exactly what you described, that you resect the best you can, but you don't get an R0 resection. How do you follow those patients, and is there any benefit from either chemotherapy or radiation therapy?
Imaging at a close interval would be the rule, again, depending on the cell type that you're dealing with. If you have a liposarcoma that is largely a bland, low-grade atypical lipoma or atypical low-grade liposarcoma, local recurrence can be picked up with imaging surveillance every 3 to 6 months. And again, you have to understand that they have a low predilection for systemic failure, but regional or local recurrence. Whereas if you had a high-grade liposarcoma, local recurrence and possibly systemic recurrence is not uncommon, so imaging of the chest would be the rule as well.
So with our liposarcoma, which you've already mentioned is the most common, usually low-grade, local recurrence is much more common than systemic recurrence or distant recurrence?
Yes, that's correct. Low-grade liposarcomas have a predilection to recur locally. However, some of these tumors have multiple components of histologic variation, like a dedifferentiated or a high-grade component that is resected, and it's usually this that you see that recurs locally. So the recurrences tend to be more aggressive histologically than the original tumor.
Well, you've already mentioned that there's numerous types of sarcomas that we see. There are a couple in CSAP-17 that raised, I don't know if you want to call them their ugly heads or how you want to describe them, but there was one that I was not familiar with, so as usual I learned something as we go through CSAP, and that is a dermatofibrosarcoma protuberans, or DMSP. Although there was some argument that it's not really a sarcoma. Do you have any comments on that cell type?
Yeah, dermatofibrosarcoma protuberans, or DFSPs, are very uncommon tumors, but anyone that deals with sarcoma will see these tumors in their practice. We like to call them the iceberg tumors because you typically only see the tip of the tumor. And I do believe they're classified as sarcomas. The cell type is purported to be from the fibroblasts of the skin, so this is a true cutaneous sarcoma, which is quite a rare thing. The interesting thing is they're all CD34 positive, so immunohistochemistry is usually needed to discern the type of tumor you're dealing with from a fibrosarcoma, a desmoid, or a DFSP. These tumors can be quite vexing to treat because of their predilection for sending little tendrils of tumor deep from the cutaneous tissues into the subcutaneous tissues and investing fascia, and certainly don't play by the rules in terms of margins. And so if you know you have one of these tumors ahead of time, large resections with potentially large tissue deficits are the rule for managing these tumors.
Is there chemotherapy for these tumors based upon their chromosomal changes?
These tumors can be treated with systemic therapy, but not so much cytotoxic chemotherapy per se, but there have been documented responses to small molecule inhibitors such as imatinib, sunitinib, and sorafenib, or the tyrosine kinase inhibitors.
And is that used adjuvantly, neoadjuvantly, or how?
Well, in general, just like any other sarcoma, a sarcoma is a surgical disease until it's not. So neoadjuvant treatment for DFSP would only be indicated for cosmetically very difficult areas or large tumors that would provide large functional deficits to try and downsize these tumors. But in general, surgery would be the first therapy.
And there was another type that we talked about in CSAP-17, which was a myxofibrosarcoma. What do I need to know about them?
Well, myxofibrosarcoma is a very similar tumor in terms of the phenotypic behavior, but basically this used to be the myxoid variant of malignant fibrous histiocytoma, which was the mainstay diagnostic nomenclature that we used for many years. Myxoid variant of malignant fibrous histiocytoma is now classified as myxofibrosarcoma, and malignant fibrous histiocytoma is now classified as undifferentiated pleomorphic sarcoma, because we have to keep people on their toes.
This is just to keep us a little off kilter when we start changing names like this. It's kind of like when we change the name of a bacteria. All of a sudden you gotta relearn a new name, but the rest of it pretty much stays the same. Is that fair?
Yeah, that's correct. But the treatment is going to be the same. It's important to understand that MFS, or myxofibrosarcoma, is typically an extremity tumor in an older patient, and that the role of imaging and to tailor surgical therapy is very, very important. MRI can be diagnostic for myxofibrosarcoma because of the signal intensity on T1 images, and on T2 images, the little fibrous bands of tumor that extend out from the main tumor can be very diagnostic for myxofibrosarcoma, the so-called tail sign on T2 images on MRI.
Now, the other one we had some discussion about was desmoids, and the discussion started with, are these sarcomas or are they not?
Not classically sarcomas in that they have very little predilection for dissemination and metastases, but they behave very much like sarcomas. The nomenclature is basically aggressive fibromatosis or disordered tumor of collagen, basically.
Is there a location that's most common? And I think everybody knows they're associated with FAP, but how about location?
Well, locations of desmoids can be almost anywhere, but the most common locations are on the trunk for sporadic types and in the mesentery on the FAP-associated desmoid tumors.
And when you've got one of these, you've already kind of mentioned that they don't have a predilection for metastases. So do we have a guideline for resection margins on them?
As with other aggressive fibrous tumors, large resections with at least 2 centimeter margins would be indicated for desmoid tumors because of their predilection for local recurrence in up to 40 to 50% of cases. They also send out little tendrils of tumor throughout various planes of the subcutaneous tissues. There's been an interesting change in recent years based on some pretty good data that a lot of desmoid tumors wouldn't be operated on up front, and an observation approach is sometimes indicated because of the large disfiguring types of surgery that's necessary to remove them completely.
And during that observation period, is it truly just observation, or are we using drugs to, quote, I've heard some people call it suppress the growth of these lesions?
Well, historically, unresectable lesions or patients that wouldn't be appropriate for large surgical procedures were treated with systemic therapy with either tamoxifen or nonsteroidal medicines such as Solandac or the combination, and the response rates were not great. These days we have chemotherapeutic options. A lot of these tumors respond to sorafenib or other tyrosine kinase inhibitors. And it's interesting, in the trials that demonstrated the worth of these tumors, spontaneous regression was noted in up to 20% of cases on patients receiving placebo. And this led to the recommendation for potentially observation.
So has aspirin fallen out of favor?
I don't know that there's ever been any real trial to demonstrate the efficacy of one type of NSAID or another. Classically, Solandac was the nonsteroidal that was used in my practice.
Now, you mentioned 40 to 50% have a recurrence. Can we lower that number in any way, shape, or form by an intervention?
Well, appropriate surgery would be the most beneficial way. If the tumor is completely resected with 2 centimeter margins and you truly have an R0 resection, there's approximately a 20% local recurrence rate, whereas if you have an R1 type of resection, recurrence is 40 to 50%. In those situations where you have a known compromised margin, then adjuvant therapy is sometimes indicated. And that could be either radiation or imatinib.
And the response to radiation on these tumors?
Actually, these tumors can be radiosensitive, and with appropriate planning with your radiation oncologist, local control can be achieved in anywhere upwards of 60 to 70%.
Now, we've been talking about local recurrence quite a bit. Let's talk about metastatic recurrence. And is the lung the most common location that we're going to see a metastatic sarcomatous lesion?
Across all subtypes of sarcoma, the answer is yes. Hematogenous spread to the pulmonary parenchyma is a very common pattern for disseminated sarcoma. Regional lymph nodes represent metastatic disease, and you can see that in some cases, but classically lung metastases would be the most common.
And is there any real benefit to resecting those sarcomatous lesions in the lung?
Well, patient selection is the rule, but in general, I like to say that sarcoma is a surgical disease until it's no longer a surgical disease. And for a low burden of disease in the chest, pulmonary metastectomy has a definite survival benefit.
You got anything I've missed that we should leave our audience with about the management of soft tissue sarcomas?
Nothing that is striking other than, again, an index of suspicion by a general surgeon for a tumor that's firm, deep, big, or growing should lead to further investigations prior to diving into the tumor. And I would just caution, if you do a biopsy and you have a fibrous tumor on an extremity, that these are the tumors that tend to get out of control with inadequate operations. So planning appropriately would be my advice.
Well, let's move on to another area, and let's talk about gallbladder cancer. And it's fortuitous today that just before I sat down with you, I was going through the general surgery communities, and there's a post on what do I do with a gallbladder polyp. So let's put it as a practical question. So you've got a patient who shows up in your clinic, and the radiologist has sent you the patient because on ultrasound that was generated for what was just called upper abdominal pain, they found a 9-millimeter polyp. What do you do with that?
Well, it must be taken in the appropriate context. A 9-millimeter polyp with a pedicle with vascular flow in a 65-year-old woman with chronic cholelithiasis could very well be something that needs to be dealt with surgically, whereas a bland polypoid lesion that may or may not be neoplasia in a 20-something-year-old male with right upper quadrant pain is almost never going to be something that is going to need to be dealt with.
Now, is there data to support size of that polyp to dictate or at least indicate that surgery is an appropriate intervention?
I would think most people that deal with gallbladder cancers on a regular basis would counsel that anything over 2 centimeters in size probably ought to have a surgical intervention, and it's unlikely that anything under 1 centimeter in size would need a surgical intervention in the right context. And I would say 1 to 2 centimeters is a gray area. Personally, I think if the patient has another indication for having a cholecystectomy, then that would be a very appropriate treatment for an incidentally discovered polyp.
So your index of suspicion climbs when it's 1 centimeter or more?
Yes, I would say that 1 centimeter with a definite polyp in a gallbladder certainly could harbor a neoplastic process that would represent the best opportunity to treat a gallbladder cancer when it be incidentally found at an early stage. So cholecystectomy is a very reasonable thing. The characteristics of the polyp on ultrasound would also guide that as well.
So in that pedunculated polyp that's 7 millimeters, and the patient is really asymptomatic when you query them closely, what do you do with that patient?
If the polyp was easily seen with ultrasound, I think surveillance with ultrasound at a 3 to 6 month interval in intervention for any change or development of symptoms would be indicated.
And then the favorite question is, how long do you follow that polyp without change?
That's a good question. It's kind of like a thyroid nodule. How long do you follow the thyroid nodules that haven't changed? At some point, there's a low probability. I would say that probably less than 1% or probably 0.5% of polyps are malignant potential, but that 1 in 100 or 1 in 200 needs to be ferreted out early.
Well, let's talk about staging, and I think everybody knows that a T1 lesion for gallbladder cancer allows us to do cholecystectomy as adequate therapy. Is that still a true statement?
The current staging of gallbladder cancer divides T1 lesions or lesions confined to the mucosa of the gallbladder as T1A and T1B. The gallbladder is interesting in that it does not have a submucosal layer, so T1B lesions are involving the muscular layer of the gallbladder wall, and those should be treated with additional surgery besides cholecystectomy. Most authors believe that a T1A lesion could be treated with cholecystectomy alone.
And obviously T2 needs more surgical therapy as well, correct?
Yes, and this is an evolving management strategy as well, but the chance to cure a gallbladder cancer is best when you have lesions that are confined to the local regional porta hepatis and that are treated aggressively with surgery. So in most cases, in the appropriate patient, T2 lesions would be treated with more surgery, the so-called radical cholecystectomy.
Let me ask you to help clarify something that sometimes was pretty clear in committee discussions and sometimes was not. So radical cholecystectomy, and the other term that we used was hepatic resection and lymphadenectomy with or without bile duct excision. So can you dissect this string of procedures for us and provide our audience with how you step up with kind of each of these more aggressive surgical approaches?
As we all know, gallbladder cancer is an extremely difficult tumor to treat, an extremely lethal disease, with most people succumbing to peritoneal dissemination or distant metastases. So the first and foremost thing a surgeon that's going to deal with gallbladder cancer should know is the characteristics of the tumor. Where was the tumor located in the gallbladder? What are the margins? Perhaps discussing with the surgeon that took the gallbladder out, if this is an incidentally found tumor, what were the findings at laparoscopy? And then prior to embarking upon any radical surgery, systemic imaging should almost always be performed to rule out disseminated disease. A lot of people will have occult disease in the lung or the peritoneal cavity on cross-sectional imaging at their incident diagnosis of gallbladder cancer. If no evidence of disease is noted, then a stepwise approach to the management of gallbladder cancer would be necessary. Most hepatobiliary surgeons would approach a potential T2 or T3 gallbladder cancer with a diagnostic laparoscopy up front to search out for disseminated occult disease in the peritoneal cavity prior to committing to a laparotomy for resection. If no evidence of disseminated disease or occult peritoneal disease is noted on diagnostic laparoscopy, then a formal quote-unquote radical cholecystectomy could be performed. In the hands of most hepatobiliary surgeons, this would include a resection of the gallbladder bed with either a formal segmentectomy of segments 4 and 5 or a wedge resection of the gallbladder bed in association with a regional lymphadenectomy. My personal practice is to look for occult disease in the aorta cable nodes or disseminated disease in those lymph nodes first. And if disease is found in distant nodal stations, then it's unlikely that large hepatic resections will be beneficial.
But if none is found, then you proceed with your radical cholecystectomy. Now, how do you make a decision about whether or not the bile duct needs to be excised?
Again, discussion with the pathologist and the referring surgeon, if appropriate, would determine whether more surgery from the biliary system is necessary. I would say in most cases, a clear cystic duct margin that has been adequately assessed by your pathologist, no further bile duct surgery would be necessary, and the only porta hepatis work would need to be done would be a regional lymphadenectomy.
So when you're through with this regional lymphadenectomy, you've really resected the porta hepatis nodes, the nodes between the aorta and the cava. Anything else that I need to do?
There's some controversy as to whether the port sites of a laparoscopic cholecystectomy was performed need to be resected, and I would say in this day and age, most people don't feel that port site recurrence prevention with resection of the port sites is of any added value. Radical cholecystectomy plus or minus common bile duct excision with a margin of liver with regional lymphadenectomy is the standard management.
Now, have we gotten any better at finding an adjuvant therapy for advanced gallbladder cancer?
Sadly, no. Responses to chemotherapy are palliative and provide modest benefit at best.
Let me change the topic a little bit. And obviously, you're in a rural practice, and you already stated you provide a lot of support for many general surgeons and many patients with advanced cancer. So can I ask you a little bit about pain management in a palliative mode? How has pain management for a patient with abdominal cancer changed recently? not necessarily in response to all the hubbub about the opioid epidemic, but just in general. Are we using more blocks? Are we using more multimodal therapy? Is CBD oil and marijuana becoming more available? Can you give us some idea from your standpoint about those topics?
Sure. This is something I take very seriously in that options for patients for care on a multidisciplinary level in Montana are limited. So keeping patients' care close to home as much as possible is something I strive to do. So the answer to all your questions is yes. Pain management is certainly a hot topic these days, and I have the luxury of having a palliative care team that I work very closely with, and I provide a lot of hospice-type services. So pain management in advanced cancer can be managed in a variety of different ways. Traditionally, opioids play a role in that management strategy. I'm fairly liberal with celiac plexus blocks, either intraoperatively or endoscopically guided or image guided when appropriate. And these can be very efficacious in the patient with abdominal cancer with uncontrolled pain. In terms of adjunctive therapies, I have very little experience with these complementary therapies, but I do realize that they have a role.
Let me ask you about the celiac axis blocks. In older literature, at least absolute alcohol is commonly used to get a permanent block versus some of the local anesthetics that are used for short-term or moderate-term blockage at the celiac axis. Which approach have you most commonly taken?
If I'm in an operative setting and I have an unresectable tumor that presents with abdominal pain, for instance, a pancreas tumor, I typically would go straight to neurolysis at that time to provide a benefit for the patient and inject 4 or 5 cc's of ethyl alcohol or absolute alcohol in the perineural tissue along the celiac axis on either side preemptively. My endoscopic ultrasound colleagues here in town typically like to do a diagnostic block with bupivacaine or lidocaine up front at the time of an endoscopic ultrasound to see if there's a reasonable response, and if so, then a follow-up injection with alcohol would be indicated.
Does it ever scare you how black the tissue gets when you inject the absolute alcohol?
Initially, when I was a younger surgeon, absolutely. These days, I've come to expect it.
Okay. David, I've really enjoyed speaking with you this morning. I see our time is about up. Can I ask you if you'd like to make any comments about the process of CSAP 17 or the process of CSAP Audio Companion? The stage is yours.
Well, I would first and foremost tell our listeners that CSAP is a powerful tool for keeping yourself educated, keeping your certification up to date, and it presents itself with a tremendous value for the practicing general surgeon in terms of keeping their knowledge base up to date. I personally have made a commitment to try to give back some of my time to the American College of Surgeons for all that they've provided to me, and I enjoy participating in the CSAP writing sessions, and I welcome the opportunity to do it. I find that I, like yourself, get extremely well educated around these times when we're writing questions and bantering about the appropriateness of questions, and it's a very rewarding part of my practice. I would tell our listeners to look at it as a wonderful opportunity.
Well, I thank you for those comments, and I thank you for your contributions to CSAP. As we get ready to start CSAP 18, I may be knocking on your door again. Who knows?
Well, I'll be happy to answer it.
Okay.
That's it for this category of the CSAP 17 Audio Companion.